Hello and welcome to SciLux, the podcast where we talk about scientific developments and technological changes in Luxembourg. As usual, we are powered by Research Luxembourg and recording at the studios of RTL City. And on today's show, our guest is Dr. Sophie Pilleron, who is cancer epidemiologist. She was affiliated with the Big Data Institute at the University of Oxford after working in New Zealand, where she was a visiting researcher at the Department of Public Health at the University of Otago, Wellington. Sophie was awarded the FNR Attract Fellowship, and thanks to that, she is the head of the ACADI, Aging, Cancer and Disparities Research Unit at the Luxembourg Institute of Health. Sophie, thank you very much for coming today.
Hello, thank you for having me.
I have to admit that for a very brief moment, I was considering to completely change the podcast and what we discuss. And I was thinking, let's do travel. Because I'm a big fan of New Zealand and I've been there once. And I was like, let's just discuss Wellington and the islands. And it's so nice. I'm really envious you actually worked there for some time.
1 year with all my family. Yes, we feel very fortunate to have lived this experience. It was just amazing. And New Zealand is, we are very nostalgic of this period. And yes.
I understand that. Yeah, it's very far away, but at the same time, it's just so different.
Yes, main inconvenience is very, very far away. Otherwise, we would have visited more frequently because, yes, we are really missed New Zealand.
You don't miss Oxford this much?
I haven't really lived in Oxford because of COVID. We couldn't move them because when I started to work for Oxford, it was July 2020. It was middle of the COVID pandemic. And so the university was closed and we couldn't travel there. So I worked from France. But I visited Oxford and I regret not having this opportunity to live there because it's a very nice city.
Yeah, totally. And definitely closer.
Yes.
That's for sure. But then at the same time, the worst would be if you were to live in France and work for New Zealand. That would be a really missed opportunity, right?
Yes. I'm just saying.
You can always get worse, always. Okay, but, I have to say that the reason why I would probably prefer to talk about New Zealand is because the research subject of yours is a tricky one. I think it's tricky because it's not as sexy as, blockchain or wwhatever else we had. When I'm trying to talk about my podcast and the subjects, the moment I say cancer, people are like, we don't want to discuss it. Yes, it becomes a little bit difficult to kind of sell it if you want, right? It's something that everyone is touched by some way or another. And especially as we will be discussing in older adults, it's even more important. But at the same time, I find it a bit tricky. So that's why, just to set up the scene, yes, I have to ask, how important is it to look at diagnosed cancer in older patients? Why this one? Why not just, glioblastoma? I had a colleague from yours at LH looking at glioblastoma. I had cancer metabolism. Older patients, what is there to look at? What is the main issue, problem, diagnostic thing to discuss?
As an epidemiologist, I started to get interested in older adults with cancer when I was at the International Agency for Research on Cancer some time ago. And I was struck by the fact there's not that many research focusing on older adults with cancer, while most of the patients with cancer are old, age over 60, 65. And there are little research compared to other age group. And as you said previously, cancer is not sexy. Older adults is less sexy. And when you combine the two,
exactly, that's what I meant, right?
Sexier.
It's a very tricky thing because you're combining two difficult subjects together.
Yeah, but cancer, it's not that tricky in research because we have the chance to be funded compared to other diseases that could be probably less fundable. And there is a big interest here in Luxembourg for cancer. So it was not the cancer part, probably the most difficult part, probably the less sexiest part was older adults, because now, internationally speaking, there are more and more focus on pediatric or childhood cancer. And yes, there is not that much fun for older adults, but it's changing, it's evolving.
Okay, and hopefully with the development of your group, it's going to change even more.
I don't have this pretension to change everything at the international level, but I hope that at least in Luxembourg, we will highlight this population and vulnerable population, yes.
So you're pretty fresh to Luxembourg. You started this year, right? So
January.
Exactly. So very much, it's just starting the group and trying to figure out. I know you're also recruiting some PhDs right now, so it's probably very, very much early to ask. But first of all, when you started, did you have access to Luxembourgish data on exactly this subject?
No.
So it was there. So you have to get this yourself? You have to do the research yourself?
It depends on which data you are talking about. My previous experience were to use cancer registry data, and there is a cancer registry in Luxembourg.
So what is that actually, cancer registry?
It records all cancer diagnosed in Luxembourg, regardless of age, of cancer type. And this data can help have an idea on how many cancer diagnoses occur every year, and information about survival and mortality among patients with cancer, and to do some description and analysis that could help inform public health policies and prevention program and such a thing. So usually that could be at population national level, but sometimes in some countries it's only in some regions, such as in France, for instance. But in Luxembourg, the coverage is national.
Okay, so you had the cancer registry, but it's not enough what you want to look at.
Yes, it would, but the data are not totally ready to be used right now. We are hopeful that in the next few years it will be okay. There's some work done by another team at LIH, but for me, I didn't plan to use them because they are not totally ready. So the idea is to use data from England, for instance. I have also the plan to work on data in France. And also, so this is a quantitative part, but there will be some qualitative research. And Dr. India Pinker just joined my team to work on that activity. And qualitative research will be used mainly to understand better how the treatment decision-making process. And we will use interviews, and probably we will observe some medical consultation to see the interaction between the physician and the patient.
As we mentioned the data, so I think this is the moment before we discuss anything else. And I want to ask you a little bit more about the qualitative methods and how you evaluate cancer treatments and all that. But before we do that, I think it will be a very good moment for you to ask the pub quiz question, because that's related to Luxembourg and the percentages. So if you can please ask the question. And listener, remember that the answer is only at the end of the podcast, so you have to listen until the end. Don't go forward, just listen.
In fact, there are two questions. So the first one would be, how many people are diagnosed with cancer every year on average in Luxembourg? And the second one would be, what is the percentage of all the adults aged 65 plus diagnosed with cancer every year in Luxembourg?
Okay, so we will talk about it at the end of the podcast, but now coming back to what you mentioned. So quantitative methods, qualitative methods. This is something that actually is pretty interesting to me, because quantitative methods, we would have to show the numbers, and it's pretty difficult to do that on a podcast, right? Because then people don't see exactly all the graphs and everything. But qualitative, you can actually describe. So you said that you have a new colleague that is going to look at this. So what is qualitative in cancer research? What do we mean exactly by that? What kind of qualitative methods? You said you are evaluating treatments in this case?
No. Qualitative method won't be able to evaluate the treatment, but to understand how the decision about treatment is made, because there are several issues when we are talking about other adults, but cancer treatment in other adults could be more complex than in younger adults, middle-aged adults, for instance, for several reasons. And so it could be difficult for physician and for patient as well, because he has to understand everything also to decide what is best anti-cancer treatment, best strategy overall, because there are several ways. So yes, qualitative research will help to understand how this decision is made, knowing that this complexity.
The complexity of taking the decision.
Yes. Yes.
This is really, I have to admit, a subject that I fortunately never had to think of that much. So I really want to understand a lot of the things. And you're saying like, oh, well, obviously it's like that. And then obviously it was not so obviously for me and probably not for many listeners either, right? So I want to go back a little bit. So we're just like, first of all, unwrapping some of the definitions. When we started and I introduced you, I said that you are a cancer epidemiologist. Before we were recording, you said, well, nowadays, hopefully everybody knows what epidemiology is. But I don't understand cancer and epidemiology. Cancer is not an epidemic, is it?
Not really. No, yes, epidemiology is a word. Epidemiology was initially used to study epidemics, but its use was broadened to other health issues, problem conditions. And now epidemiology aims to describe health and disease conditions at population level and to understand when, why, how, and in which group of people these diseases could occur to inform public health policies and intervention. So now even there is an epidemiology of traffic accidents. So it's really very large now.
Okay, so that's one
thing. So cancer is a disease. And yes, we are studying this disease.
Okay, now it makes sense to me. Thank you for explaining this. And then what about geriatric oncology? So that's basically cancer in older patients, or not?
Yes, that's it. It's a specialized field of oncology that focuses on the diagnosis and treatment of cancer in older adults, just as there is a specialized field of pediatric oncology for children. There is also a need for specialized care for older adults with cancer.
So now we have this and this. We set up the scene. After, 15 minutes, we have the scene. So I can also ask more. So you said, all right, maybe you didn't say that, but I do remember when I was reading some articles or maybe watching you online on YouTube, you were saying something about the fact that when we look at diagnosed cancer in adults, because here we're talking about adults, the cases among the older adults are prevalent. So we have more cases among older adults, but the treatments are more tricky. So then why is that? You mentioned a little bit.
For several reasons. So the first one is that older adults may be very different one from one another. We all know 70, 75-year-old person who is very fit, who is able to walk or cycle kilometers, and other 70, 75-year-old people who see their health declining with more and more medical events and problems. So even within the same cohort of adults, there is a very big heterogeneity in terms of health and fitness level. So we cannot propose the same treatment for a fit patient as for frailer patients. And although as we age, the likelihood to have several health conditions increases and may complicate cancer treatment. This is often correlated with several medications that may interfere with cancer treatment as well. We can have also difficulties in hearing or seeing, or we may have cognitive disorder that may also complicate treatment because these impairments may impede the understanding of instruction regarding adverse treatment effects, for instance. Also, older adults are more likely to have a reduced social network that is important to help manage cancer treatment and accompany them throughout the cancer journey. It has been shown that persons with a diverse network of social support have increased survival compared to people with no social support or with smaller social support network. And so all these medical and social factors have to be taken into account when deciding about cancer management strategy, as all these factors influence cancer outcome. This is one related to the patient, but there is also other adults underrepresented in clinical trials.
But why? They just don't participate? The calls finish at 65? What's the problem?
Yes, there are several reasons why older adults may be underrepresented in clinical trials. One reason is that older adults as I said, often have several health conditions, what we call comorbidities, which can make it more difficult to meet the eligibility criteria for clinical trials. In addition, other patients may be taking, as I previously said, multiple medications that could interact with the drug being tested in the trial, and so it may make it more difficult to assess the safety and effectiveness in this particular population. But also, other adults...
That's a long list.
Yeah, sorry, but because it's not that simple.
Yeah, of course.
And there are
I
many
didn't say so.
factors explaining that. So, but another reason is that older adults may be less likely to be referred by their physician to clinical trial because probably the physicians are not aware about available trials or have some concern about potential risk or benefits of participation. And there may be also some not that obvious barrier to clinical trials that more related to logistics. Because, for instance, older adults may have mobility issues that prevent them to go where the clinical trial is taking place. So all that could explain why older adults are underrepresented in clinical trials. However, fortunately, the situation is evolving. And regulatory agencies such as the US FDA for Food and Drug Administration recommend now the inclusion of older adults in clinical trials. Geriatric assessment in older adults with cancer were recently published, and there are ongoing clinical trials that are recruiting adults aged 70.
Okay. Voilà. All right. Yes. A lot of different facets and a lot of things to think about at the same time. It's a very big equation. So then, of course, I'm a journalist. I have to ask the question, what's the solution? Precision medicine is a solution or it's not a solution?
So precision medicine in oncology is often referred to the tumor. So it's to develop and use a right drug for the right tumor. But for other adults, it's not enough because we are not sure if the new drug developed can be used in other patients. But yes, geriatric medicine in general, and in particular geriatric oncology, is a personalized medicine by definition because you have to consider many factors and into account when you decide about the best cancer management strategy. So yes, geriatric oncology is a personalized medicine per se because we need to take, as I previously said, I won't probably go repeat that, but because of the comorbidities and so on, so we need really to take that into account when decided about best strategy.
Jumping a little bit, because one of the previous episodes that I had was, of course, about this, I think the biggest hype that we had in years almost, so ChatGPT, right? So I was obviously checking your Twitter account and I noticed, Sophie also asked ChatGPT. And I love the fact that in a way you were not commenting. At the same time, I didn't like it because for me, as not a specialist in the field, I didn't know what was the problem of the answer. And probably there was something. Or maybe ChatGPT was genius. I don't know. I want to ask you. So, of course, for people who don't know, Sophie, you asked 2 questions to ChatGPT. One was about geriatric oncology, so definition, right? And the other one was about role of nurses in that. And then you just posted it there. So I guess what I was missing was the commentary. How did ChatGPT deal with those 2 questions?
Very well, because it was kind of passages from textbook, Okay. So it's doing very well because ChatGPT just work with the data that he was trained with. So yes, he performed very well for definition of geriatric oncology and the role of nurses and geriatric oncology.
Which just makes me think that I'll just stop inviting researchers and just for definitions at least,
Yes. I think he performed quite well for definition, but it doesn't perform as well. At least the ChatGPT 3.5, yes, you cannot use it to write an article, a scientific article for sure. That's
at least not in your field.
In any field.
Okay.
No, but because it's not precise. It doesn't think. It's just a machine. It doesn't think. So, no, it could help for me, with not a native speaker in English. Can help a lot with editing, like writing assistants. Even for that, you need to double check every sentence because, as I said, it doesn't think and it doesn't know what you have in your mind. So sometimes it's not as clear.
It's very interesting what you're saying, because I'm referring to an interview I had with Dr. Alexandru Adrian-Tantar about ChatGPT. Of course, he's an IT specialist, so it's a different way of looking at that. And we stopped at the moment, what does it mean to think? Right? Because, of course, there are different definitions of that. And you are just very, very clearly saying it doesn't think. But it's true that, it's a large language model. And what it is very good at is finding collocations, right? So just finding words that like each other, that go together, and not what you're expected if you want to write a scientific article. Who knows where we'll be later on. But for now, why did you decide to ask those two questions?
I was very curious. I just tried ChatGPT, I think 3 weeks ago or something like that. And I was a bit afraid to try it before because, yes, I think it could be dangerous, But I was really relieved to see that.
Not yet.
Not yet. We won't be replaced by ChatGPT.
At least for now, right? And it also depends who.
Useful tool.
Yeah, absolutely. And I think the moment we embrace it, the easier it will get in certain fields, at least, Although, I don't know, for podcasters, it's a little bit scary as well with all the AI-generated sounds and voices and everything you can do right now. We'll see. Hopefully, we'll stay with the human touch.
We don't have choice now. We have to follow
No, we totally don't. So going back, we went a bit further away and we're now back to discussions. So you just listed all those different, challenges that we have to look at. When it comes to what ACADI is going to do, you're just starting, but what's the plan for the next 5 years? Where are you heading with the research?
So yes, I was fortunate to have this 5-year funding thanks to FNR, and so it gave me kind of basis to develop my research activities here in Luxembourg. The aim of the research group, is to improve cancer outcome in older adults to reduce age disparities in cancer outcome. And so cancer outcome, what do we mean with that? It could be very large. It's just, so far I was more interested in survival, but survival won't probably be the best outcome of interest when we are interested in older adults. Probably quality of life could be an outcome that we may be interested in. And yes, it could be also toxicity. It could be several things. So we don't have the direct translation in French, but it's not a question here. But just cancer outcome, it's kind of broad. So
it's very broad. So the outcome of having cancer.
Yeah.
Of course, a positive one. That's what you're looking at in this case.
Yeah, but when to reduce the negative one.
Yes, I understand. And when you say toxicity, what is meant by that?
It's adverse reactions that you can get with chemotherapy, for instance.
Okay, yes. Now I get it. Okay, sorry, continue, please. If you remember where you were.
So as ACADI research group aim to improve cancer outcome in older adults. And so we will work at different phases on the cancer journey. So we will work before the diagnosis, because we know that older adults are more likely to be diagnosed with cancer at a more advanced stage than younger adults. And I would like to explore the factors around that to know why, because there are very few research on that topic when it's in older adults. There is a lot of research on screening, cancer screening and so on, but not because older adults are not targeted by the National Cancer Screening Program. That doesn't give a lot of information about the reason for that. So I would like to explore this period. After that, as I mentioned earlier, there will be a part of the work around the treatment decision-making process, where we will be mainly use qualitative research method to explore how the treatment decision is made. There will be another body of work who will be about, as I mentioned, older adults are underrepresented in clinical trials. We have little evidence on the effectiveness of treatment in this population. And there are some statistical and analytical methods that can be applied to observational data. So observational data could be cancer registry data or could be hospitalization data and that kind of data. So the idea is to apply this method to the observational data from the UK probably and France to understand, to have a more evidence on the effectiveness of treatment in older adults, or at least to give a bit more information about that. And finally, there will be work around to kind of develop a tool to predict risk of early death and toxicity in older adults using geriatric elements, because usually prediction models that regardless of the method used, that could be, the idea is to use artificial intelligence method and machine learning in our case. But usually they don't take into account specific factors for older adults, such as comorbidity, such as social support, such as cognition, for instance, because older adults may have some cognitive disorders, things like that. But it will be much later.
That's bad that it's much later, because that's something that got me interested. So probably it's, will not be able to tell me much about it.
Not yet.
But I did see that you were talking about something like prediction researchers. And I was thinking like, okay, well, that's something I didn't know that the researchers do, that there is a bit of prediction in the work. So what is that? Why were you looking for this?
What I call prediction researcher in bad English, because I'm not sure that's a right.
Whatever, it got me curious.
Researcher working on predictive research. Predictive research is a very productive research field, especially in medicine. It aims to develop models to make prediction based about future events, such as death, could be toxicity, could be complication, based on past data using specific statistical and analytical methods. And in medicine, there are many prediction models developed, at least not that many used. And so this tool could be used to help to make the treatment decision about cancer and other diseases, obviously. However, prediction models are not quite crystal balls, and their accuracy depends on the quality and quantity of the data being used, and as well as statistical and analytical method being applied. They are just tools and don't replace the clinical judgment of the physician. And so yes, the idea is to develop useful tool and specifically for older adults. But there are a lot of research. It's a really active field. So we'll see what we can bring new, because there are several things happening, especially in the US on this field.
So something clicked in my brain. You'll tell me if this is correct or not. So your affiliation with the Big Data Institute. So the Big Data Institute is about also predictive medicine or not? Because we have big data, and when you have big data, it's all about machine learning and, predicting outcomes.
Also, Big Data Institute is a very big institute, so there are a lot of things.
So it's actually a big institute, not big data.
Not Big Data Institute. Yes, there are some teams working on artificial intelligence and machine learning. I don't know if they are working specifically in predicting. But yes, they are predicting, but not for older adults, for instance. But yes, but we won't collaborate. But it's not planned yet to collaborate with them first, because we have the skills at the LIH.
Yeah, of course you do. I know. Just mentioning that because I thought that maybe there was something related to the part of predicting when you were working there.
Yeah, so prediction is not my primary area of expertise, but it's something that I think we should do if we want to help.
Of course.
Other adults.
Of course.
To make a decision.
I listened to your lecture that is available online, the one from Wellington. Yes, exactly. And I really liked, maybe I shouldn't say I liked it because it's not so positive, but at the same time I found it very interesting, this quote that you used from Dr.
Sophie Pilleron.
Exactly. We harm and then we adapt. And I guess what you also said about the ACADI group is to kind of change that paradigm a little bit.
Yes, that's correct.
Yes, so let's hope that you will have enough people and enough resources and time, because it's very ambitious for 5 years. I think that you'll manage to do all this. But before we wrap up our discussion today, of course, we have to come back to the question you asked in the beginning. And as usual, I will ask you to ask the question and then give us the answer.
So the first question was, how many people are diagnosed with cancer every year on average in Luxembourg? So the response is about 3,000. And the second question was, what is the percentage of adults aged 65 plus diagnosed with cancer every year? In Luxembourg, it's 58%. It's about 1,725 cases every year.
And if you compare it with other adults, it's kind of a classic situation that there's more.
Worldwide, over half of cancer diagnoses are diagnosed in adults aged 65 plus. Yes, and this number will increase, will almost double.
How do you know it will double?
We make some predictions.
Yes.
Now, projection would be more accurate based on demographic. It's just based on this prediction are based on demographic projection, because population is aging worldwide, so automatically the number of cancer will increase.
We are based in Luxembourg, so I have to ask that question. Do you notice any specificities for this country or not really when it comes to cancer research, cancer treatment, or you're not focusing on that? Because as you said, the data you'll be analyzing, partially at least, is going to be from the UK, from France. It's kind of more an international approach, right? But is there something also related to Luxembourg as such?
I don't know yet if Luxembourg has some specificities. Quantitatively speaking, it will be difficult without having data. After, we will learn more when the qualitative research will be conducted.
Then we will invite you again to tell us more.
Yes, and if it's about the qualitative research, probably you should invite India Pinker to talk about her work.
Totally, and also, not based on any official research, I definitely know that there are quite a lot of older adults in Luxembourg, that they continue being here present. So I'm sure there will be a lot of research to be done, and I'm very curious to see what's going to happen next. So let's talk about it. Just to remind our listeners that in our podcast series, we also talked to your colleagues from LIH, of course. And when it comes to cancer research, we had already cancer cell metabolism with Johannes Meiser. And then we had also Anna Gołębieska from LIH talking about glioblastoma. So we have quite a few people representing LIH and talking about that. So if you got interested in the subject, do check the other episodes out. And what remains is to thank you for today, Sophie, for coming and telling us a little bit more about this world that was totally new to me.
Thank you for inviting me.
And as usual, listeners, don't forget to subscribe, to follow us, to check us out, especially on LinkedIn and Twitter, but also Instagram. We try to put some kind of shorter snippets from our episodes and some other things. And let me just say, as usual, that this was Silex, and my name is Hanna Siemaszko.